Well, this has been extremely informative. Before we end this discussion, I'd like to get some closing thoughts from each of our patients. I'll start to my left with Max. Closing thoughts?
So I think I learned on my own a lot, hear all the opinions. I think it's important to have a clear relationship with the pathologist to get biomarkers, to decide on the biomarkers which drug is the best. We have IO combination with chemotherapy now for all non-small cell lung cancer patients, non-driven, and even biomarker-driven patients will receive in later lines perhaps the combination IO plus chemotherapy. And I think when we compare our landscape 10 years ago, we just gave chemotherapy. Now it's much, much more complicated. We can discuss much, much more. We have subgroups like RET, BRAF, ROS1, EGFR, ALK, where we have different substances as different drugs that we can use. And it's more exciting for the patients and more exciting for us.
Tom?
I think you hit on a critical thing, the integration with the pathology and the biomarker selection, because I think that's really critical to do that up front. I'm excited with the potential of liquid biopsies. You know, I think they're not going to necessarily replace tumor biopsies, but I think that they may help us with the patients who have insufficient tissue or other problems. I think immunotherapy continues to be sort of the dominant paradigm for most of our patients. I'm eager to see the 227 data in its totality. Because I think the next big question is there going to be a double immunotherapy combination, or is chemotherapy the best platform to combine immunotherapy with? Need some work on the mechanisms of resistance for the people who progress on immunotherapy, because it's a very heterogeneous patient population, and I don't think clinical factors are going to be sufficient to really guide us.
Leora?
It's hard to follow those. You know,
I'm sure you can come up with something.
Probably. You know, it's never been a more exciting time. There is so much data coming out, so many options for therapy for patients. You know, in the U.S., there's still a lot of patients who don't get treated. And how do we get that message out that there are well-tolerated options, that, you know, there are good drugs, there are things we can test you for. And, you know, just expanding on what Tom said, not only understanding the mechanisms of resistance to immunotherapy, understanding who should get these drugs to begin with, and how we should give them, and who should get combination therapy, and who should get single agent therapy. You know, we're sort of just at the tip of understanding who should be getting the checkpoint inhibitors. And for targeted therapies, how do we make the response and plateau those curves as well as we do with checkpoint inhibitors for that group of patients? I think that, you know, we've still got a lot to learn.
Suresh?
I think to me the big excitement is the potential for improving the cure in stage 3. Okay. And the big challenge is, how do we beat the Pacific regimen? I think the design of clever trials and broader identification of biomarkers to see who should, you know, we have to finally try and differentiate it, because for years we've been saying stage 3 is a heterogeneous disease and we need to tailor the approach, so let's do it for stage 3. And for stage 4, to me, the big challenge now is to try and design trials with locally ablative therapy. The low volume oligometastatic disease, I mean, yesterday the presidential was also in prostate cancer, the STAMPEDE trial. The low volume disease, they're showing a survival benefit for addition of radiotherapy. So we have to keep in mind the majority of patients either don't respond to IO or fail at some point. So, you know, could we do standard approaches with or without radiation? And I think that abscopal effect is, to me, not a reality yet. So it's more like, you know, tailoring, sequencing the right modalities. Stereotactic radiotherapy, for example, locally ablative, upfront from one arm, and on indication for the other arm. That would be a useful way to see how we could help patients, but that needs big trials.
Yeah, I think you hit the nail on the head when you said it's a very exciting time. I mean, I started in lung cancer when, as a fellow, we would argue about whether or not lung cancer could be treated at all. And, you know, there were trials of platinum-based therapy versus best supportive care. And when you think about it, it's really only 25 years ago that we kind of endorsed treatment as changing the natural history of the disease, and to see where we've come nowadays with a plethora of an increasing number of molecular subtypes with targeted therapies, so kind of targeted therapies in targeted patients, and then the whole, what I refer to as the immunotsunami over the past couple of years, where we now have really, in those patients that are eligible to receive immunotherapy, we pretty much give it to everybody, and the argument is, who gets monotherapy, who gets combination therapy? If you get combination therapy, what's the best chemotherapy platform for that sort of thing? So it really is an exciting time. And it gets down to us having the ability to help our patients more. I really think people are living longer and living better as a result of all these changes we've made in therapeutic options for patients. So thank you all for your contributions to this discussion. On behalf of our panel, we thank you for joining us, and we hope you found this peer exchange discussion to be useful and informative. Thank you for joining us.